Welcome, clinical problem solvers. Welcome another Wednesday. Good evening, good morning, good afternoon, wherever you are. It's a summer evening here in Peru, but it's summer, but it's not that hot, as I was talking with Deborah before starting the meeting. So today we are here with Jack and with Madalena and Deborah facilitating the case. So Deborah actually has a case for us, so we're ready to discuss. And if it's the first time you're joining the Wednesday sessions, we usually make it very didactic with the audience. So we're not going to ask for specific volunteers, but if you have any thought or opinion, just put it in the chat, and we will highlight your comments as the discussion goes on. So maybe I can pass the mic to Jack.
Thank you so much, Bali. It's great to see everyone here today. Thank you all so much for joining us. I am, as always, super pumped to get to talk through a case and think through some medicine with everybody. Before we get started, I think one of the traditions that I've been trying to adopt is seeing if there's anybody who's here with us today for whom it is your first time joining VMR ever. Feel free to give like a thumbs up or type in the chat if it's your first time ever joining VMR. Oh, I see Tom is giving a thumbs up. It's Tom's first time joining VMR. Tom, are you in a place where you can unmute and share a little bit about yourself in terms of where you're joining from and what exactly brings you here?
Yeah, absolutely. Can you hear me?
Yeah,
cool. Yeah. I'm a first year medical student in New York City, and I heard about the channel and watched some of the videos on the website and found it incredibly helpful, especially right now when I'm just learning all the details and have a lot of everything's very disparate. It's really very exciting to put it all together and think about a real person and how to actually do the job. It's very exciting. So thank you.
Tom, we are so excited to have you here. Would love it if you would also share, New York City, first year medical school. Have you lived in New York before medical school, or is this your first time living in New York City?
I lived in New York for a few years, doing research here in various capacities. But so I've been here for a while.
What are some of the things you enjoy about being able to live there?
The density and the proximity of people is very cool. I actually quite enjoy it. You meet a lot of people that you would not otherwise run into, and they shape you and they make you. And you see yourself being formed by all of those offhand interactions that seem like they're transient, but they're actually very important, and they build up over time, and they make you into a different person. I won't say better, different. I appreciate it.
I dig it. It sounds a lot like learning medicine in terms of the way in which we encounter cases. And I should say too, I don't know if you saw in the chat, Madalena as well is also a fellow medical student in New York City as well. So you are amongst.
Yes, welcome, Tom.
Thank you. That's awesome. It's nice to meet you.
And then I think we also had Josue and Rhea, who were also either first and or second timers. Josue, do you mind unmuting and introducing yourself?
Yes, hi everyone. My name is Josue. I'm a 6th-year medical student from Peru. What else should I say? I am interested in internal medicine, and I'm glad to be here with you guys to learn some medicine in English. It's my first time discussing cases in another language.
Well, we are so excited to have you here. Thank you so much for joining. What do you like to do for fun outside of coming to clinical reasoning conferences during your evening time?
Well, I love playing football, or what you guys call, I think, soccer. I also like surfing and hanging out with my friends.
That sounds great. You and I both share a love of the ocean. I was actually today sneaking away from work to watch the current surf contest happening at Sunset Beach. So I would love to talk about that with you sometime. And then last but not least, Rhea. Rhea, do you mind unmuting and introducing yourself as one of the second timers to VMR?
Hi, everyone. I'm Ria, actually not Rhea, but that's okay. I'm from India. I just finished med school back in June last year. And I really enjoy internal medicine, and I hope to someday work in the States as well.
Amazing. Thank you so much. And thank you for correcting me. It sounds like Ria is the correct pronunciation.
Yes, thank you.
Thank you. Thank you. No, seriously.
Yeah.
It is like always a gamble every time. I hope I'm pronouncing it right just by reading it. And it's so helpful when people do correct us. So thank you. And thank you for being here. It's great to have you. All right, Vale, I'm going to kick it back over to you. Do we have a case for today, Vale?
Yeah, actually, Deborah has a case for us. So I just wanted to check if, Stephanie is already here. She was signed up to scribe, so I'm going to make her a co-host. I also wanted to shout out that Josué is actually from my school too. So it's really nice to see us representing, I guess. So Stephanie, let us know when you're ready. I saw you on the Excel that you were scribing today, so thank you so much.
I don't know how to get to that Excel to like sign up, so I'm sorry. That must have been a miscommunication on my end. But I'm gonna be completely transparent. I've never scribed before for this, so I'm just probably gonna need some quick guidance.
Maybe I made a mistake. I thought you were Stephanie Travis' student. No, okay, so that
yeah, Dr. Smith.
Yeah,
That's me.
Okay.
Yeah,
Okay.
I've never done I've never like led as a scribe, you know what I mean?
Yeah, no, don't worry. I've been there. The first time scribing for me was also I was very nervous. So no worry, you have access to the whiteboard.
Mm-hmm.
Okay, perfect. You're a co-host now, so you can share the screen and everything. And don't worry that we are gonna be there helping you. And if you have any need any special help or anything, we are totally here for you. Thank you so much for having.
All right.
Okay, so maybe we can. So maybe now, Deborah, you can start presenting the case and start with the first aliquot.
Okay, I wait for this screen, for the whiteboard.
And again, just another plug for while the case is unfolding, please do share your thoughts in the chat, and Vale and I will be absolutely thrilled to ask you to unmute and share your thoughts out loud, particularly if this is one of your first or second times joining. And so we want to make sure that we get as many voices represented as possible, and the more voices that we have, the better we're probably going to be able to solve the case.
Okay, I will start. 84 years old male presented in the emergency room with dyspnea and hemoptysis. Should I continue or no?
Why don't you go ahead and give us the rest of the HPI, unless Vale, okay. unless you want to talk it all right. All right, yeah, we can get a little bit more. I'm already nervous.
Okay. The patient has a little presented to a fatigue plunge. I guess that's the way that I said. That was difficult to clear, and the history of present illness. He reported no weight loss, no fever, no chest pain, no dysphoria. He denied he denied international travel or previous contact with someone with TB or SARS-CoV, and he had no occupation exposures, and he smokes.
Amazing. And just to clarify before I kick it over to Vale, you said it was 2 weeks of symptoms?
No, I didn't set the time. He showed up and okay. Was like with hemoptysis and dyspnea.
Okay. Vale, I'm going to kick it over to you.
Yeah, so the first thing that I would like to note, just because we don't have a lot of information just yet, maybe the patient was having massive hemoptysis, so the volume will be key. And also to see what are the vitals of this patient. If the blood loss is huge, then of course it's going to be an emergency. And the fact that he's also dyspneic, and so well, we have the dyspnea pyramid, in which we prioritize pulmonary causes, cardiac, and then other causes that could be also blood loss in that category. But definitely just kind of having a Venn diagram of dyspnea and hemoptysis, the pulmonary system overlaps for me in that sense. And that could include stuff going through like maybe a vasculitis that affects the pulmonary vessels and could also lead to hemoptysis, or something affecting the airway that could also lead like something more traumatic, or even something digestive that is not a true hemoptysis, but like hematemesis that could present the same way, and the blood loss is causing the dyspnea and not necessarily because the lungs or the heart are the main organs affected. And so I think first, what I will do is establish the vitals and see if this is a massive hemoptysis. If the patient can give us more information about the time onset, I think will be key. Also, and then to see if this is something truly from the pulmonary system or it's coming from the GI system, in which case I would like to rule out the possibility of hematemesis secondary to maybe esophageal varices in case of massive hemoptysis, and the prior history of cirrhosis will also be, key. So so maybe Jack, what are your thoughts on this?
No, I think you really highlighted what is like one of the key challenges when we're faced with the chief concern of hemoptysis, which is to answer the question of are we coughing up things is the person coughing up blood that started in the lungs, or are they coughing up blood that got into the lungs from somewhere else, like the upper respiratory tract, for example, epistaxis, or is it actually vomit rather than coughing things up for like in the setting of the GI bleed, as you mentioned. And the ways that we can do that is oftentimes through the history, but then also through imaging findings that we may have. And I will say, even before going down that historical route, hemoptysis is a very scary chief concern because there's a huge spectrum in terms of the severity that we can have. So if somebody is having massive hemoptysis, right, where they're coughing up cups rather than spoonfuls of blood, that becomes a scenario where we're going to prioritize treatment over diagnostics. And so when I see this chief concern of coughing up blood, the first thing I want to know is not what's causing it, but does the person have a patent airway? Is their respiratory status stable? And are we potentially going to need to intubate them to make sure that we secure their airway effectively? Once we've answered those questions and said like, okay, we're maybe not dealing with something emergent, then we can turn our attention towards the schema that you listed, Vale, which is it coming from the nose? Is it coming from the GI tract, or is it actually coming from the lungs? And once we know that it's coming from the lungs, I sort of take basically a two-side approach to it. One question is the problem in the lung parenchyma, or is the problem in the vessels within the lung itself? Because really hemoptysis, if it's coming from the lung, just means that there's an abnormal connection between the blood vessels and the airway that's basically that's pushing things, or that's pushing blood into the airway. And so parenchymal problems can be anything from something as mild as bronchitis to something as sinister as an endobronchial tumor or an aggressive infection that's eroding into the blood vessels. If it's a vessel problem, we could be dealing with something like a fistula, right? So sometimes we can have a fistula between the airway and one of the vessels. We can have a problem in the capillaries, like diffuse alveolar hemorrhage, or we can have a problem in the veins, like severe decompensated heart failure, leading to elevated pressures within the blood vessels. But I think really before we start to focus on the lungs, we have to answer the question that Vale brilliantly articulated to start off. And then once we know we're in the lungs, I think we can use the branch point of, is this a parenchymal problem or is this a vascular problem, to help refine our process. And I think that's going to depend on both imaging and some of the exam findings. And so I'm super stoked to see where this goes.
Okay, nice discussion, everyone. Talking about the past medical history, the patient had a complete atrial ventricular block that required a permanent pacemaker. He has moderate to severe COPD. He has rheumatoid arthritis that he treats with oral prednisone. He has big chronic lymphocyte leukemia and treated with methotrexate and prophylactic of oral supplemental of ferrous sulfate. He was going to the doctor because of a peptide ulcer, atrophic gastritis, and a colonic diverticulitis. And the last, he had a thoracic surgery and of an acute mediastinus from an odontogenic infection. The vital sign, if your girls lost something, I can send in the chat. The vital signs, the patient was afebrile, no fever. The heart was 58. The blood pressure was 118/68, and the saturation was 92 in the air. The patient was alert, orientated with normal mucocutaneous coloration and perfusion. Pulmonary, he has rales in the both lungs with no other pulmonary alterations detected. And cardiovascular was normal, abdominal was normal, everything was normal.
Thank you, Deborah. Before starting the discussion on this aliquot check, I wanted to highlight one of the comments from Param on the chat. They ask any pearls questions you can ask to quantify severity of hemoptysis regarding massive hemoptysis. And that's actually a really good question. So what are your thoughts on that?
Oh, it is. I would be delighted to answer and know that there's also a lot of people on here who have far more experience than I do. And so please feel free to chime in if others have thoughts. I'm sure that there are quantities that define massive hemoptysis from non-massive. I honestly don't have them in my head to recall, nor have I really ever been able to formally measure hemoptysis, particularly when it's a life-threatening scenario. So what I usually ask is like tissue or towel or teaspoons versus cups. And if somebody's coughing onto a tissue and there's a small amount of blood, that changes than if they're using a lot of tissues or sort of like having like a lot of blood coming out of their mouth to the point that it would soak through a towel. And then teaspoons versus cupfuls is also helpful. Like if somebody's coughing up a lot of sputum and for example, they have like a sputum receptacle at the bedside and we see blood that they're coughing up blood and it's filling up that cup over the course of maybe a couple hours or so, that's a very different scenario than the person who coughs up a little bit of blood only a few times per day. And so I think both the quantity that they're coughing up and then over the time course is what I use. And again, I think that like tissue versus towels is a helpful way to think about it. Towels obviously being massive hemoptysis, or if they're using a bunch of tissues. But I'm curious if anybody else knows in terms of like the actual quantities that we start to think about as the cutoff point. I see Gerline mentioning things like airway compromise, and if there's potential respiratory distress. Gerline, do you mind sharing a little bit more?
Hi, everyone. Yeah, I was just thinking that in terms of, it's hard to like quantify, as you were saying, like the actual milliliters or like amount of blood, but just thinking about when you're assessing a patient for hemoptysis, is there signs of like respiratory distress? Like, is it hard for the patient to like have an effective cough? Is there like emergent like ABCs, like airway, breathing, circulation in terms of their O2 sat, if there's worsening hypoxemia, if there's more emergent treatment that needs to be done before like thinking about the diagnostics?
Perfect. Great.
Okay, so to tackle this aliquot. So, well, I think first of all, the vitals of the patient are not quite reassuring for me. The blood saturation makes me think that this could be compromising the respiratory system and kind of makes the possibility of something coming from the GI system less likely, although maybe the person could have hemoptysis and then just swallow it, and that could cause also obstruction. But so that this iteration is something that worries me, as well as the heart rate that I would expect it to be just higher. And even though the patient, I mean, his blood pressure is within normal limits, still I would think that it is, we still don't have the measurement of the blood loss yet, but these vital signs make me think that it was not something not significant. And the rails in both lungs also makes me think of something pulmonary being the focus of the problem, or just like the blood obstructing the airways as a possibility. And just the past medical history, the history of COPD, that could also make me think of maybe something. I'm not sure if that will be something so abruptly. And then again, we don't have time onset just yet, but I'm assuming that it was sudden in presentation. And I'm not sure if the history of rheumatoid arthritis, maybe something vascular happening over there, just that's what came to mind, but I'm not sure. What are your thoughts, Jack?
It's a great question. I think I appreciate immensely how honest and authentic you're being to the reasoning process right now, because I'm right there with you that, you know, the data that we can gather is that there's hypoxemia, there's something in the bilateral lung, but it's really hard to quantify things further from there. All we really have at our disposal is framing the probabilities of some of those things that you mentioned initially, based off of the background medical history, right? So Vale told us up front that, you know, is this epistaxis or is this something from the GI tract potentially making its way into the lungs? And I would say that, maybe I can reframe that saying, is this epistaxis that's leading us to cough up blood, or is this a GI bleed that's leading us to cough up blood? And I would say that given that we have hypoxemia now and the finding of rails in both lungs, the probability of something making its way into the lungs is much higher. Whether that is blood that is sort of, whether there is bleeding into the lungs that's happening, or whatever was happening in the GI tract or the or the nasopharyngeal cavity being aspirated down, something seems to have made its way to the lungs. And in terms of trying to decide what is potentially causing this process that's happening in the lungs, which seems to involve some blood, we have to look to the background medical history of this patient. And to be honest, there's a ton of things in the background that could help us explain hemoptysis. Vale, I think you picked up on the COPD phenomenally well as a risk factor. Certainly individuals with COPD and chronic bronchitis, they could have some blood-tinged sputum. That's usually going to be small amounts of hemoptysis, more in our tissue or teaspoon category. I see some people mentioning in the chat sort of questions about the past thoracic surgery, which I think is a very important thing to tune in on. I would be curious to hear, Deborah mentioned that she's not sure when the timeline was. That can become important because if we think about when somebody has a tracheostomy placed, that tracheostomy tube will sit right sort of here at the sternal notch. And right below that is something called the innominate artery. And sometimes if there's something sitting on that blood vessel or close to it for a long time, it can potentially erode into the blood vessel and create something called a tracheoinnominate fistula, which is one of the life-threatening causes of hemoptysis. And so if this was recently there or currently there, we might think about the tracheostomy as being a potential culprit for the hemoptysis. Unlike chronic bronchitis, that's usually going to be a large amount, right? A towel or cupful of hemoptysis, because it's an arterial bleed into the pulmonary space. Other things that I think are potentially coming out based off of the background medical history is the fact that this is somebody who has rheumatoid arthritis and is on prednisone and methotrexate. And so maybe there's a component of underlying immunocompromise, which if we were to find, say, something like a cavitary lesion on the CT scan, we might think about a cavitary lesion and a indolent bacterial, mycobacterial, or fungal infection as the explanation for this process. So I think honestly, like at this point, Vale, I'm like, there's more questions than answers, but at least we're starting to find that the center of gravity is gravitating towards the lungs here. But I really think it's hard for me at least to make progress without seeing, Is this a diffuse pulmonary process or a focal pulmonary process? Because that will really help to narrow the DDX. Most of the time, the vascular problems will have a diffuse process, and most of the time, the parenchymal problems will have more of a focal process. And so that's going to be one of the things that I'm looking for if we get imaging, which I hope Deborah gives us, but realize this could go in a lot of different directions. And before moving on, I see that there is a great comment here from Namisha, and Namisha, please correct me if I didn't pronounce your name correctly, but do you mind sharing a little bit more about what you learned here that you shared with us in the chat?
Hi, thank you for asking about my input. So I was just reading about the definition of massive hemoptysis, and it seems to be very variable. The usual definition that we use is a volume of expectoration from 100 ml to 1000 ml in 24 hours, but we don't have consensus on that definition. So that's why it's much more important to look at the clinical sequelae for the bleeding rather than fixating on a certain volume. It's a very good idea to have a rough estimate of whether the bleeding was severe or not based on what you said about using the table versus tissue approach. But I think it's really important to remember that it's more about the clinical sequelae rather than just the amount. Thank you.
Thank you so much. Thank you for teaching us. That was phenomenal.
Of course.
All right. Vale, any other thoughts before we get some more data here?
Yeah, I just wanted to kind of echo what you were thinking about the possibility of infectious causes also being on play, and also another possibility could maybe be PE. I know that, I mean, it is one of the causes of acute or abrupt dyspnea that we wouldn't want to rule out. And also in the infectious category, infections that could cause bronchiectasis, like TB, but TB can also cause, for example, cavitary lesions. And I mean, within that, also bacteria can cause bronchiectasis and cavitary lesions as well. So yeah, just broadening the possibilities, also something autoimmune maybe, but yeah, I just wanted to echo that. So right back to you, Deborah.
Okay, everyone, great discussion. I hope I will answer all the questions. If I don't, please forgive me. Talking about the labs, the hemoglobin was 12, the leukocytes was 48.8, the lymphocytes was 35.6, sodium 141, potassium 5.4, creatinine 1.2, D-dimer was 1,141, COVID and TB was negative. EKG showed a normal sinus rhythm with a normal PR interval and wide key RS complex with T wave was negative D3, AVF, and B3. The CT scan showed a blurred ground glass opacities and endobronchial continent, predominantly in the left lower and up lower, and in the left lower and upper lobes. And let me see if I'll see more. And the bronchoscopy showed a diffuse brownish coloration surround the area of the left bronchial airway, and then nodular mucosa that suggests an infiltration. I'll stop there.
I wanted to ask you, Jack, or maybe anyone in the audience, if you have any thoughts in the chat, because what do you think, or how do you explain the low heart rate in this patient? Because I would expect it to be just way higher.
It's a great question. I think I will not pretend to know the answer. I do note that the patient has a pacemaker. And so I wonder if there's some component of what we would call chronotropic incompetence. So they have a AV node that seems to not be working well. And sometimes when someone has AV node dysfunction, even when they have a pacemaker, they may not be able to mount an appropriate tachycardia in response to stress or blood loss or fluid loss. And so I wonder if we're seeing this sort of entity of chronotropic incompetence here.
Thank you for that. It's the first time I listened to that. So thank you.
Yeah.
So what are your thoughts on this aliquot, Jack?
Oh gosh, I think just scanning it here to process it, it seems like Deborah, correct me if I'm wrong, but we have an extraordinarily high leukocytosis and an extraordinarily and it seems like that was predominantly lymphocytes. Is that right?
Yes. Yes.
Okay. Not neutrophil predominant. And then just to go through the CT scan
No,
again.
wait. I said the leukocytes. Just checking if I said it right now. 0.8. Okay, I'm writing the chat. Sorry.
No, that's okay. And then the CT scan was diffuse ground glass opacities and then some stuff in the left lobe. And then they saw nodular mucosa on the bronchoscopy. Is that right?
Yeah.
Okay. So I think, there is one hypothesis that we could go down here with a white count that's high, or that is that high, which is that this could be actually a clonal proliferation of white cells that could be related to something like a leukemic process, right? So could there be an underlying new diagnosis of leukemia? We see that the blast count is really high. And so sometimes individuals can have acute lymphocytic leukemia or chronic lymphocytic leukemia, which Della is very generously mentioning to me that was in the past medical history. Della, you are saving me about 30 seconds of discussion here. Thank you so much. I am blushing enormously because I just missed that in the past medical history. So you have saved my butt. In which case, I'm just going to focus on the imaging findings now. So the diffuse GGOs, right? We know that ground glass opacities can be pus, blood, water, or cells. And it seems like in this case, there's maybe some signal that what we're dealing with is blood. The endobronchial contents on the CT scan and the bronchoscopy, I think further suggests that there is blood in there. And then in terms of the nodular mucosa that is suggesting infiltration, I actually am having a hard time knowing what to do with that. I sort of have like a general schema for what types of things can cause infiltrative processes. And it's usually going to be infections, malignancy, or some rare diseases like sarcoid or amyloid. Amyloidosis can manifest in solid organs via soft tissue lesions, but is usually not going to have a characteristic soft tissue nodularity, but that's certainly possible. But I think where I would be leaning towards is this a new malignancy on top of the leukemia? Is this a complication of the leukemia itself, or are we dealing with some sort of aggressive infection, which you've already given us a great DDX for, particularly thinking about potential mycobacterial or fungal or bacterial infections. But I think beyond that, I'm having a hard time here and would love to hear your thoughts, and then also the thoughts from the rest of the group.
Yeah, that's amazing, Jack. I actually, I was also thinking about the past medical history of leukemia. I didn't catch it either, so that's great. I just wanted to mention that, okay, so the anemia, we don't really have anemia, but that's okay because from such an acute blood loss, there can be hemoconcentration. And so we should check maybe the anemia in a few hours later, the hemoglobin, sorry. And then also wanted to comment on the D-dimer, because when I saw it, I thought, okay, so maybe could this be a PE before thinking about the WBC? But actually the D-dimer is not specific for a PE, just will help if it's low and to rule it out. So just wanted to make that point. And this patient, I mean, I'm not sure what your thoughts are, Jack, but I wouldn't think that has a lot, well, they have malignancy in their past medical history, so maybe that's the point that favors PE, but the very, very high WBC makes me also think about malignancy. And in the nodular mucosa differential, I'm also really lost. I'm not sure what type of malignancy could present like this. I know amyloidosis, sarcoidosis could present like this, infectious etiologies. I'm thinking paroxysmycosis, I think, and present with nodular mucosa infiltrates. But then again, I'm not really sure. And I think at this point, if a biopsy was not done, it will be necessary to maybe see what is going on there. But I think malignancy causing the pulmonary involvement, or maybe an infection coexisting with malignancy, or the possibility of amyloidosis, as you suggested. I don't know if you have any other thoughts.
No, I mean, really, I think, yeah, I'm with you. I think if I were to sort of frame the probabilities, I think would lean more towards the malignancy bucket. Again, like, it's quite rare, but certain leukemias can have soft tissue components to them. Like CLL, while it's primarily a hematologic malignancy, it can have soft tissue clinical manifestation. So I would be curious, like, are we dealing with a new soft tissue complication? But then also endobronchial tumors, like primary lung cancers, can also lead to the development, or can also lead to hemoptysis, like we're seeing here. I think one of the things that we have to reconcile is that it seems like there's nodularity throughout the whole airway mucosa, which may be atypical for a primary tumor, but certainly certain cancers can infiltrate throughout a large portion of the airway, so it's not impossible. And then I think the other possibility from a cancer perspective, if it's not primary lung, is that are we actually seeing metastatic disease from another site that we haven't yet identified? But it's pretty, I mean, it's not impossible, but it's maybe not typical to see somebody have two cancers strike badly at once. But if that is the case, this would be a very unlucky gentleman, and I would feel absolutely terrible for him. So I think, you mentioned tissue and biopsy sort of being the ultimate issue here. I would be I'm very curious to see where we go there, because I think it's hard, at least for me, to again narrow down to a definitive diagnosis just based off of the bronchoscopy findings alone. So I'm very excited to hear from what Deborah has to say.
Okay, I'll go for the last aliquot, and from here I'll say the diagnosis. So the biopsy showed the deposit of the brownish material in the submucosa, epithelial cells, and with necrotic tissue. And the histochemic showed there was positive golden brown pigment that was concordant with iron accumulation. And the bronchial washing confirmed the biopsy, and the diagnosis was iron pill induced bronchial injury, that the name is iron pill aspiration syndrome. Like I was with like you guys, I never thought of that diagnosis, and I have some teaching points to bring here. What I read about it, it's that this incidental aspiration, happens more with elderly patients that have a lot of multiple comorbidities, like this patient. And the diagnosis, it's not easy because the symptoms are inspecific. And in this case, they stop the iron, and then the patient has to do bronchial washing and then take corticoids, and he gets better.
Wow, it was crazy. I wasn't expecting that at all. I was expecting like, okay, so biopsy showed malignant cells or something like that, and then iron. And we totally skipped on the medication. We just skipped right through the steroids and methotrexate and skip through the ferrous sulfate. I had no idea that it could cause massive hemoptysis. So, I mean, you can confirm that it was massive hemoptysis, or what was the volume that you saw the patient had?
I don't have that information. I'm sorry.
Oh, okay, no problem. Thank you.
I am absolutely floored. I would love to hear reflections from the group in terms of the final diagnosis in this case. I have never heard of this diagnosis. Has anybody heard of iron pill aspiration syndrome before? Yeah. No, Judge Imran, I would say that somebody who has heard of the diagnosis would probably be the only one. This is a great case. And it seems like a pretty positive diagnosis for the patient. Like, this is something that he should recover from and do well. as opposed to some of the other things on our differential. But yeah, if anybody has thoughts or reflections on this, please do feel free to unmute and share your thoughts.
I don't know, I would talk a little bit. I guess every time when we do a case, everyone in the chat or the discussion try to say something. And then I was expecting, oh my God, someone will say something. And then I said the bronchoscopy with brownish and no one said anything. I said, oh my God, no one noticed that. And nothing, doesn't have too much cases reported about that. I was reading a paper, like they found like 40 and nothing. Yeah, I don't know if anybody else never heard the, please share your thoughts with us.
You're totally right. I mean, I didn't have like a differential of brown bronchoscopy findings, so I would totally skip on that and the bronchoscopy that you shared with us. I wanted to ask you if the lymphocyte count, it was the basal of the patient or they had a relapse or the malignancy as well?
Great question. I don't know because the patient has the leukemia too, so great question. I don't have all the past medical history, sorry.
Okay. Thank you.
Deborah, you're getting a lot of shout outs in the chat for bringing such an amazing case. Yeah, I would say that, you know, Deborah, you mentioned that maybe the iron staining of the walls of the bronchi was a clue here to this. And I was like, oh, that's just related to there being blood in the airways. And like the blood itself has just stained it. So it's a cognitive reframe for me to realize the ways in which I was anchoring to some other potential cause of hemoptysis. But just from doing some like brief Googling as we've been sitting here, it seems like the iron pill itself is quite caustic to the airway tissue. And so in addition to it can sort of create this huge inflammatory response, as you were saying, that can lead to bleeding. And then the pill oftentimes dissolves, but it leaves its trace with the brown airways. Well, this was a fantastic case. I would say this is one of my favorite VMR cases are the ones where it's new or where it's familiar words put together in a way that I've never seen before. Like I've certainly have heard of aspiration, have certainly heard of iron pills, but iron pill aspiration as a diagnosis is brand new. Madalena, I know that you have done a ton of work in putting together teaching points from this case and really teasing out some phenomenal learning. And I just, before turning it over to you, want to thank everybody for all of your contributions in the chat. Want to thank everybody who shared their thoughts out loud. A particular shout out to Namisha for sharing the definition of massive hemoptysis and really helping us learn about sort of the importance of the clinical scenario. And then also want to give a big thank you to Tom, Ria, and Josue for joining us for either the first or the second time. We really hope that you'll think about coming back and joining us. But Madalena, take it away with teaching.
Great, so amazing case discussion and case presentation, Deborah. So I have some teaching points from this great discussion. So the first is that when someone presents with hemoptysis, you first need to think about if the patient needs immediate management and intubation. So things you can look for are signs of respiratory distress, hypoxia. You can want to take a look at their vitals to see if you need that immediate management. We also had a great discussion about trying to quantify the severity and the amount of the hemoptysis, because sometimes the patient doesn't know exactly how many milliliters they've been coughing up. So some helpful questions can be, have you been coughing into a tissue or a towel, teaspoons versus cups, just basic questions like that to get a general sense of how much hemoptysis there is. And then a really helpful branch point when you're thinking about the differential diagnosis for hemoptysis is to think about the location of where the blood could be coming from. So you can kind of bucket into, there are three buckets you can think of, the tracheobronchial system, the lung parenchyma, and then the vessels. So some examples of the tracheobronchial causes could be a neoplasm. We talked about an endobronchial tumor, bronchitis, bronchiectasis, for example. For the parenchyma, you can think of cavitary lesions caused by various infections like TB, lung abscesses. And then on the vessel side, you can think of fistula, vasculitis, or PE. Moving on to imaging, when you think of ground glass opacities, you want to think of, is it pus, blood, water, or cells? And then second, for infiltrative processes, you can again think of those buckets of infection, malignancy, and sarcoid. We talked about D-dimer as a test when used for a PE. And Vale mentioned that it's a very sensitive test, but not specific. So it's not helpful to rule in a PE, but can be helpful when ruling out. And then lastly, this brings us to our diagnosis of iron pill aspiration syndrome. And Deborah gave some amazing teaching points of her own that generally it's caused by just incidental aspiration of iron pills. The patients who are at risk for this are generally elderly patients, who may have difficulty swallowing. And then someone in the chat gave some great, potential pathogenesis, which I'll have to look up, but that potentially the iron pill itself is, damaging and can lead to hydroxyl free radical formation. And I think Erlene gave a really helpful infographic that we can take a look at as well. So thank you, everyone.
That was wonderful, Magdalena. Thank you so much. See you all tomorrow.
Thanks so much, everybody. And a big shout out to Stephanie for scribing and getting all of those tough case details down. Thank you so much, Stephanie. We really appreciate it. See y'all soon.